Dr. Shepherd, it is so great to have you on the Sakara Life podcast. Welcome.
Thank you so much. This has actually been something that I've been really looking forward to. I mean, for many reasons. One, because after I met you, I was like, okay, one, I'm in love. And then two, the product, which I've known for many years, is something that I think is phenomenal. So this is an amazing time to spend with you both.
Amazing. Yeah, we recently met at Eudaimonia, and you said to me that you had been ordering Sakara through the pandemic.
Yeah.
So that's so great to hear. Well, we like to start every podcast with the same question, which is, what is your mission here on Earth?
Oh, I love this question. And they sound sometimes so simple, but they really do make you dig deep to reflect. And when I think of my mission here, I really do believe that I am an advocate of helping people find their best wellness journey, specifically, obviously, for women, but helping people really accept themselves through their journey in wellness, but also being exposed to so many of the possibilities of what that journey can look like.
Amazing. Well, today we really want to dive into what that looks like during menopause. I think menopause is such a hot topic right now, which is a good thing because it wasn't talked about for so long. And like we said, I got to meet you at Eudaimonia and I got to hear you speak. And the stuff you were talking about was just mind-blowing to me. We've had a number of guests on the podcast who are all amazing, but you said some things that I hadn't heard yet. So I was like, we got to get you on the podcast to talk about these things. But I really want to start with diving into some of the science and what's happening inside of the body during menopause. So what is going on with our hormones?
Yeah, and I'll even back it up to perimenopause because shameless plug in my book, Generation M, I kind of label it and section them out to the pregame, which is perimenopause, and then the main event, which is menopause. But I like to bring it back to perimenopause, one, because I find that that's actually more of a confusing time than menopause. And then also we have the opportunity to prepare during menopause for menopause. So if you were to look at both of these stages, perimenopause is this fluctuation of hormones that are getting prepared for the main event menopause, and where estrogen, namely, is really going to take this deep dive and not necessarily give off as much as it did, almost to no degree of what it used to during our reproductive phase of life. And so during that perimenopausal phase, you start to see these fluctuations because the body is preparing for the main event. And in that preparation, which can be over the course of 3 to 7 years, goes through this fluctuation, which is why we start to feel a little bit of these changes, whether it's with our mind or our bodily symptoms, then going into menopause. So menopause is such a clinical term, and that's why I really like to start with the perimenopausal phase. Menopause really is a clinical term that says when a woman has gone 12 months consecutively without a cycle, then she is now hit menopause. So if you wanted to actually think of the term, it really just highlights one day, because now we can say, okay, yeah, for the 12 months prior, she has had no cycles. Now she's hit menopause. And then from there on out for the rest of your life is what I like to say is your postmenopausal, because you've kind of passed this time frame of this clinical term of a day. And so that's why it needs to be looked as kind of this stages and phases of one kind of preparing and going into the other, where we can hallmark with this term. And then our lives that time after is the postmenopausal phase. So it really is this beautiful bridge of things that are occurring for a whole body. And I don't like to typecast it to just the ovaries. So many people just think of estrogen, ovaries, that's the whole experience, but it really is a whole body experience. And we'll be able to explore that throughout this, this session here, because even from the nutritional aspect or the brain health aspect, there are features of menopause.
What's one of the earliest signs somebody can start to understand when they might be hitting perimenopause?
Yeah, that kind of hallmark, I would say, are the changes in a cycle. And so whether it's irregular, spotty, it gets heavier, it gets lighter, you miss a few months, that typically is one of the hallmark signs, because again, the fluctuations of hormones, your body's trying to respond. It's like, what's going on? Okay, we're not doing this today. Okay, we are doing this today. And so that disrupts the cycle. But some of the other symptoms that, my patients, complain of are changes in kind of like cognition when I think of like memory or being able to multitask or just forgetting something in the middle of a sentence. You start to see those changes as well as occasional hot flashes and night sweats. Those ones are not as frequent as when you maybe are like fully menopausal, but they may be. But what I find is that it's so jarring that people's like, did I just have a hot flash? And then they may never have one for maybe a few months or maybe even a few years, but it really is this kind of edging into these things that are happening.
And what are some of the kind of lifestyle practices one can have in their like 20s and 30s?
Yeah.
Because I would imagine something like, insulin resistance or poor sleep habits or, gut health all impact perimenopausal symptoms. So what are some of the things people can think about in their 20s and 30s to really think about their perimenopausal phase not being as... I have friends where it's like so tough, and then I have friends that don't even really notice it.
Yeah, I think, going into the body of self-awareness, because this experience, just like you said, is going to be different for everybody in the intensity or the frequency or just their mindset in how they go through changes in their everyday life. People really treat their overall experiences differently. And so even from that standpoint is the self-awareness of what is going on with my body. Am I paying attention to it? Am I honoring it? And from that, when you can have better conversation, whether it's with your healthcare provider, your circle of friends. And then when we actually go to things that you can do is being prepared is changing my diet as I maybe go into my 30s, is starting to incorporate more protein into my diet or more fiber into my diet, because you do know that is going to be a big part of the perimenopausal transition. So why not start incorporating over a course of time? Because we all know lifestyle changes and habits are one of the hardest things to do because it can never be an overnight thing. And so that experience through your 30s might be, how can I change my nutrition to incorporate what we talked about, protein and fiber, but also my workouts? Even for me through my 20s and 30s was a lot of cardiovascular, which is not a bad thing. Very helpful, really good for that time frame in our life and what our body is trying to accommodate and accomplish. But as we start to get into losing muscle mass, needing protein to increase the uptake of glucose as we go into our 30s and 40s, is how now can I start to incorporate more resistance training, weight training in my 30s? So when I get to my 40s, it's already something that I've started.
Mm-hmm. And I feel like, so once you hit perimenopause, that is typically when somebody would think about hormonal replacement therapy. Can you talk about what those hormones are we're trying to replace? Like, I have a friend who's done testosterone. I have other friends who've done progesterone. Like, what makes you decide what we should use and why? And is there a difference between the bioidentical versus not?
Yeah, that's, I think, kind of when we think of like the playground for hormones, which in my book, I call it the ABCs of HRT, is to, again, understand that there is a plethora of options that someone could have when it comes to hormones. So in the perimenopausal phase, we used to not treat women with HRT. We would wait till they were menopausal. This was how we used to practice. And now we are coming into the age where we understand that in the fluctuations, women will have symptoms. So the goal of HRT, typically in the perimenopausal phase, is for symptom resolution. And usually hot flashes, night sweats, change in maybe libido, change in sleep patterns. That's where we start to factor in, what should this look like from a provider standpoint to be able to offer my patient? And this is the artistry of HRT. It is never a one size fits all. And so the artistry of saying, hey, if you're having this particular symptom, then maybe we should focus on estrogen. So for example, hot flashes. Estrogen is going to be like game changer for that. If you have someone who has sleep changes or disturbances, progesterone typically is going to be that hormone that highlights that and helps solve some of those issues. And then libido could be a testosterone feature. So even with those just three things and looking at the hormones that that kind of impact it. It doesn't necessarily mean I'm only going to get that one because I have this one issue. Most people come in with a kind of a tapestry of different issues. So that's when we get to say, let's do a little bit of estrogen with progesterone. Let's do progesterone only, or let's do the full combo of all three. So it should be, and this is why I think that these conversations are so important. It really should be this, where are you in your symptoms? Where are you in how you're feeling? Now let's taper and really get these hormone offerings in the form of HRT back to you. And when we talk about bioidentical, this is where we get a lot of confusion as well as what's bioidentical, what's not, what's good for me, what's not. So I always like to say there's a full arena. People need to feel comfortable in what choices they make, but they can make better choices if they know the full understanding of what HRT provides. And so that's why bioidenticals, I think sometimes people get kind of tied up with it has to be this thing. Bioidentical really just means if you were to look at the chemical structure of the hormone as it is that your body gives off, bioidentical is very similar to that chemical structure of what a molecule of a hormone looks like. And so then you also have pharmaceutical made or lab made hormones, which is what you would call more, I guess, pharmaceutically made. So you can get bioidenticals that are actually made from a pharmaceutical. And then when you think of things like compounding pharmacies, they make bioidentical forms of hormones. So that really should be a very important part of the conversation. So you understand where they come from, what bioidentical means, what natural means, which usually means bioidentical. Is it compounded? Is it from a pharmacy? Did the pharmacy make the bioidentical? So you see, you could get like all tangled out. So I think that once people have a full understanding of what that means, then they're like, oh, okay, well, now let's go to the discussion on what hormones I should take.
I want the one that works best.
Is there a kind that you recommend one over the other when it comes to bioidentical or not?
Try to give people the full array of what's given so they can choose. And this is why, is I feel that I will find someone who comes in and in my head, I might think, they're probably going to pick this one. And then when I give them the full array, they may pick something else. And I'm like, good thing I didn't assume that that's what they would pick or only offer them this, because here they are picking something else. Or you have people who change. They're like, I'm coming in and I know I want this type. Great. And then they use it for, 3 to 6 months or even longer. And then they come back and they're like, let's talk about that other option you discussed. I may want to switch to that for these reasons. So it really should be like, I always say it should be like, I wouldn't really endorse eating there, but Cheesecake Factory menu, where you're like, why is this menu 20 pages? But at least I have all these options. I'm going to figure out which one is best for me.
And I think one thing that's interesting that you said was that you're really kind of treating to the symptoms here, because I think a lot of people think that they need to have their hormones tested and then get the right exact amount of hormone to replace, get them back to where they were when they were younger.
Yeah.
And that's not exactly what you're talking about.
No, absolutely not. Because hormones are never going to be at a certain number that we as physicians or healthcare providers should say, we have to get you back to this exact number. Because every day hormones fluctuate. They are very much, if I were to draw hormones at 2 p.m. on a Tuesday and then draw it again on a 6 a.m. Wednesday, they'll be completely different. Where are you in your cycle? Are you perimenopausal versus not versus menopausal? So it really doesn't make sense to say, I'm only going to focus on numbers and values and where you were at this age versus this age, because that's not how the body functions in general. So I'm always saying, we would love you, for example, as a menopausal woman, when we think of estrogen levels or testosterone levels, for you to be in this range. Do I know how you're going to feel within this range? Not necessarily. And some people maybe symptom resolution be slightly above or slightly below, being like, I feel great. And I'm like, great.
And is there a longevity component to hormone replacement therapy? Like, I think, I remember there was a study that came out in the last couple of years that was like, you age in these kind of like super, I don't know if it's true, like something in your 40s and something in your 60s. And so I would imagine that's connected to hormones. So Is there this like longevity / anti-aging component of hormone replacement therapy? Like not just symptoms like hot flashes, but I don't know, feeling like you're not going through that super aging period of your life?
Yes, this is actually like the exciting part of the conversation. One, because it is not very widespread as far as how we factor hormones into a longevity. And when we think of longevity, that comes with this pillar of aging, right? Which we all biologically will do. So let's take it back to the term longevity. Longevity really is, as we all start to age and get older and our bodies biologically go through this process and maybe not doing the things that it used to, what do you want that to look like from a performance perspective or for the ability to offset disease perspective? And that's where we get a choice in longevity preparing and the earlier that we start. And I think that hormones specifically play an important part in that because when we think of hormones and hormonal balance, this also contributes to living a longer and healthier lifespan, and that's longevity. So I always, when I, counsel my patients, and even in the book Generation M, I really want people to understand the scope of hormones when it means for symptom resolution and going through the perimenopause, menopausal transition, but also for longevity. So what we do know, and there's a lot of data to support this, in longevity is going to need to incorporate the beauty of hormones and hormones, other hormones as well, but specifically estrogen, progesterone, and testosterone. And there is a role in what they play in healthy aging. So for example, testosterone. Testosterone is one of those hormones that a lot of times was never tied to women and women's health. But what we do know is that reductions in testosterone biologically for women also triggers a decline in muscle mass, bone mass, and also physical function. When we think of like just outright strength, those things are going to be impacted. So if we know that, what can we do to offset that? Obviously with nutrition and exercise, that's a fundamental part of longevity. But also giving ourselves back a level or a layer of testosterone is now going to impact our muscle mass in a positive way and our physical function in a positive way. So these are some of the things that when we look at deficiencies in hormones, that has actually been shown to predict a level of health status or longevity in older people. So I always try to put them in two pillars so that people can conceptualize them. Okay, I'm addressing hormones for this particular thing, which might be symptoms, but now I want to also focus on it from a longevity perspective. And that's where I think I thrive in being able to offer experience and information in the menopausal transition is longevity.
And heart disease is actually the number one killer of women.
Mm-hmm.
And I think that surprises a lot of people. Maybe they're thinking that it's something else or breast cancer.
Yeah.
And so how does hormones play a role in that?
Yeah. So I usually have this beautiful diagram, and it's actually in the book as well. But when we think of we kind of had like if we were to like be writing a movie and typecasting menopause, we usually typecast it to the ovaries and estrogen, right? Those two things. Sometimes we forget about progesterone and testosterone and other parts of the body, but the menopause experience is a truly whole body experience. Why? Because there are estrogen receptors all over our body, in the muscle, in the brain, in the bone, in the heart. And so when we think of the organs that actually do benefit from estrogen because there are receptors, when we have a decrease in estrogen, then that target organ is not going to function as well as it could because it's not getting the estrogen receptivity or the ability for estrogen to really act on that organ. And so when we think of heart disease, what we do start to see is aging is going to happen, but the decline in estrogen is going to then impact our vessels, right, which carry our blood, and how stiff they are, which they're not supposed to be stiff, or the amount of plaque that is deposited in these vessels, which then leads to the heart not functioning as well, and then leading to heart disease, which is the number one killer of women. So all of these things start to stack up. And it's like this, have you ever seen those layer cakes that have like 12 layers because they make each one of them thin? It's similar to that. So it's like we're not creating these sustainable layers for our organs to function well. So how do we recreate that? And how do we kind of take this experience of menopause and estrogen to another level so we can create a better layer cake.
And does if you're replacing, the kind of hormones needed, does it prolong perimenopause? Does it like push out the menopausal day?
No, it actually doesn't, because the ovaries kind of like are on this time clock, and they know what they're doing. And so they're like, I'm kind of on my way out, but thank you so much for, giving the body, another reserve, I guess you can say, of hormones to offset the symptoms. So the ovaries are like, we're smart too, and we're on, on a time clock. Yeah.
Yeah, that makes me think about, that as your ovaries reduce the amount of hormone they produce, a lot of people have said that that's one of the reasons why weight gain happens, is that the adrenals try to take over and help the body. And if your adrenals are kind of burnt out because you've been hustling your ass for all those years, then then your fat has to take on some of that hormone responsibility. So if you're supporting your body through this HRT, does that kind of take off some of the burden from your adrenals and your fat? Does this help reduce that kind of weight gain that happens?
The adrenals do take a hit when we look at cortisol. Cortisol really is that hormone that has a correlation with stress and inflammation. So there's that component of as well. But like I was explaining before, receptors are all over the body when we think of estrogen receptors are. So they're even on the fat cells, right? So how the fat responds typically is they can shrink, they can grow, they can atrophy, they can increase in size and number. But when estrogen decreases, you actually start to see the receptivity of what fat cells can do decrease. So a lot of times, not only do they not respond as well, meaning, can you stay small, fat cells? They don't, shrink as well, but they also migrate. So that's typically why we see the estrogen declining. Now we start to see a shift in where fat is deposited. The actual location go from hips and butt when we were cute and in our 20s and had these really small waistlines and then nice hips. It starts to migrate to the abdominal area, which is, again, where we start to see a lot of the frustration with weight gain. Has to do again with estrogen. But another big important part of why we start to see weight gain is insulin and glucose, and that whole dynamic between the two. Insulin and glucose really is, and mitochondrial health are really the engines of how the rest of our body responds, especially with glucose. Glucose is a fuel. It's needed by the body, but when it's not absorbed and shuttled to where it needs to go, what organ it needs to go to, it sits. And when it sits, then it converts to fat at some point. And all of these little mechanical things, again, that whole layer cake, we start to see shifts in how that layer cake looks. And sometimes it's a little lopsided. So the goal really is to kind of buffer the system through exercise, nutrition, mindfulness, decreasing stress, maybe, incorporating hormone replacement therapy, looking at micronutrients and how you sustain your body with that so it's not deficient, and getting that layer cake back to that nice tall layer cake that we see.
And how do people typically use like hormone replacement therapy? Like, is it always a cream? Is it an injection?
Yeah.
Is it a pill?
It's all of it. Estrogen is maybe the most popular. When you think of like the popular hormone for women is estrogen. So there has been a lot more studies and effort that has gone into how to provide modalities of estrogen. So for estrogen, for example, you have pill, you have patch, you have cream, you have gels, you have injections, you also have pellets. Progesterone, a little bit of a stepchild, but still very important. Modalities for that include, you can do it where it's in the mouth, called like a troche or a troche, where it dissolves. You can do a pill, a cream, and that's usually the kind of the modalities in how we see progesterone. And then testosterone, which is not FDA approved for women, because of course, for so long it's thought of as a male hormone only, which we do have a source of testosterone, comes in injection, and also cream, and then pellets.
And what about the location of where the cream is?
Yeah, that's important for testosterone. Typically, we have women apply it to inner thigh area or maybe the tricep area. For estrogen, typically for creams, we put that on the forearm. And it can be done on the belly as well. And then patch usually on the belly or the lower back or maybe the side, like the hip area. Mm-hmm.
And is that just for best absorption where it's placed?
Yeah.
Because I've heard about some people, I mean, even wasn't it in that Sex and the City movie where Samantha is, putting
like the yam
hormone cream. Yeah, the yam cream, like, on her labia.
Yeah, you can. And there are some women that we can actually use testosterone cream on the clitoral area as well. So yes, there are different areas depending on absorbency, or a lot of times to where in manufacturing or studies that were done on that specific cream where they placed it on there. On the body during that study, because then that goes to, we know that this has been tested in this place, and this is how we know how it works, and based on absorption rates as well.
And if somebody's looking to maybe have a child in their 40s and they think maybe they're experiencing some perimenopausal symptoms, is hormone replacement therapy something you talk about, or how do you kind of bridge this conversation with the fertility conversation in your 40s?
Yeah, the fertility conversation is, again, a very delicate kind of personal conversation in the sense that it can trigger someone really emotionally if we're talking about what the ovarian reserve and what the ovary is responsible for and what it's giving off, is because it does. We said that before. It's on a time clock. It is so, we don't get to control that, and people have different reserves of what their ovary does, or when it starts to decline, and the, kind of the quality of your follicles and your eggs. And so those are conversations that should happen to me earlier. What are your plans? What would you like to do? What do you see yourself doing in the next 5 to 10 years, so that you can plan better, whether that's with egg freezing, and being prepared if you need it later. Because no one should have to say that I'm not going to plan to do the things I want with my life without, and I don't want to be penalized for it. But that still requires the conversation of preparation. So when we have women who are in their 40s, we know that the ability to naturally get pregnant after the age of 35 does decline, but it doesn't mean that you can't get pregnant. It's just that it's a little bit harder because your body is like, I'm not necessarily giving off as many eggs as I used to, or the quality of the eggs that I'm giving off are not what they used to be before. So that's the biological part that I would put on the list of uncontrollable. So what we can control is preparation. How healthy is my body in order to sustain a pregnancy in that age after 40? And then the other thing is, if I am starting to decline or go through perimenopause, that's also going to impact the ability for me to have fertility. But again, there are some women who, with naturally, can get pregnant spontaneously. And then those who do require help from, an infertility specialist to help adjust the ovaries, or to help adjust rather the hormones that are released from the ovaries to get them to ovulate in order to get pregnant. So there's a lot of nuances behind that conversation, but we don't typically give hormone replacement therapy as a form to kind of bolster back a fertility perspective, right? It's different.
I have a number of friends who have given birth in their 40s.
Yeah.
And they're saying, this perimenopause paired with postpartum hormone fluctuation needs to become part of the conversation, because they're like, is this just postpartum hormones? Is this perimenopause hormones? But they're feeling a little out of whack, and they're not sure what to do. What do you say if somebody has had a baby in the past year or so and are feeling that way?
Yeah, what we have seen with a lot of women who have had babies either in their later 30s and up until their mid 40s, do find that with, I guess you can say, and when I say stress, I mean like a good stress, the stress of pregnancy has really skyrocketed their hormones, because that's what happens during pregnancy. And then after they deliver, it's a very short time frame in where they start to have these changes that signify perimenopause. It is quite interesting, and a lot of women actually do experience that. Now, I don't know if I could quite quantify a statement that explains that short duration, but it again may have something to do with this kind of acute stress of the hormones going up with the pregnancy. And then after that, kind of like having this shell shock into and going now to a much lower level, and those symptoms being experienced maybe much quicker than if they hadn't been pregnant.
So could HRT help them through that to maybe soften it a
Yeah,
bit?
so there's also the nuance or kind of the delicate balance of in the postpartum phase, there is going to be a natural progression from a very high level to a low level. But then also in that, we have to consider, are you breastfeeding and for how long? What are the symptoms and are they actually just from the significant decline in hormones? Because even women who are in their 20s and 30s do notice some hormonal changes right after pregnancy because of that sharp decline when it's exiting the body from, I'm not in pregnancy state anymore. So there needs to be a longer conversation how long the symptoms have been experienced for. Is it a normal postpartum change in hormones, or are we kind of moving into a perimenopausal phase? And if you are considering HRT, but then also if you are breastfeeding, what do we do with that as well? And finding that, the best place for someone to feel comfortable, but to still be able to do what they want to do in a postpartum phase.
And, I've heard about, women having issues with like having sex and pleasure and like the tissue in your vaginal wall can thin. And so having sex can be more painful or you can experience dryness.
Yeah.
Is that something you think HRT can help with? And I've also heard there's like these lasers you can do now too that help with all of that.
Yeah, I do all of those in my practice. And if I had like a little like a game show buzzer, it'd been like beep, 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 beep. Yes, for HRT, if you're having vaginal dryness. Because when you think of the receptors again, there are a lot of estrogen receptors in the vagina, which is why it's actually able to sustain childbirth vaginally. The estrogen allows the tissue to be very distensible, flexible, a lot of blood flow in the area. So that's why we're able to push out 7, 8, 9, 10-pound babies, and then it goes back to the size it was. Game star, show, winner, estrogen for the win there. So when you start to have a decrease in estrogen, that's why you start to see the distensibility or the elasticity of the vagina decrease. A lot of women come to me with these micro tears after sex because it's abrasive. And that has a lot to do with the decline in estrogen. So, and for women out there, actually, this is a great segue into if they've had a history of breast cancer and they're like, we cannot take hormones, vaginal estrogen, you can also take. So this is one of those avenues in where women who have had a history of breast cancer can actually say, I too get to take a part in hormone replacement therapy with vaginal estrogen. Study came out last year that really looked at just for breast cancer survivors. What is that rate of recurrence of breast cancer if they're to use vaginal estrogen? And they were not able to find increase in recurrence or all-cause mortality. So that's great. And then for women who haven't had a history of breast cancer, I think vaginal estrogen is one of the safest, easiest ways to transition into HRT that's going to impact the vaginal tissue, allow you to help with sexual intimacy, allowing you to not feel discomfort when you're having sex. So vaginal estrogen, I'm like always there for. I think everyone should explore if they should have it.
Can we talk about breast cancer a bit more? I think that that's a common fear when we're talking about hormone replacement therapy. So, there was a study a number of years ago linking hormones to breast cancer, but it sounds like that has been debunked.
Yeah, I think
walk us through that.
When we think of like PR, what messaging goes out there, this was a PR fail when we think of that study, which was actually 20 years ago. It's astounding to me because I was training when that actually came out. But that study really it wasn't a poorly managed study. It wasn't a poorly thought out study. What happened was when they were doing the study and started to see some increased causes of breast cancer, was they did the due diligence in saying, let's stop that part of the study because of this number. What happened is media took the information in a way that was not really helpful. And pretty much put out there, because everything is clickbait, and what message you actually put out there was that estrogen causes breast cancer. And even in the healthcare industry, that was the message that went out. And that was not the actual correct finding in the study. It was actually the use of a synthetic progestin that increased the rate of breast cancer and not actual estrogen. So now here we are, fast forward 20 years. And basically what we do know is that in some instances, breast cancer can be protective for the breast. So there's a beautiful book, is that Estrogen Matters, and that was written by an oncologist. And an oncologist who does the study of cancer is still even saying that estrogen does not necessarily cause breast cancer. Now, someone who might have an increased incidence, or increased, not incidence isn't the correct word, increased predisposition of having a hormone receptor positive cancer, if they take estrogen, it might precipitate the cancer from coming, but the cancer was already there, if that makes sense. Does that make sense? Where you're like, the cancer was already a very high risk of coming. So,
I mean, is that if you get tested for the genes, or how do you
Right.
know if you're predisposed?
Yeah, so if you have a strong family history of breast cancer, meaning you've had a family member, first degree relative, who's had breast cancer, and typically breast cancer at a younger age. Because women get breast cancer when we think of lifetime risk at an older age. That's
What is older?
like 60s
Okay.
into 70s. And so when we think of cancers, our bodies are all have cancer producing cells. It's just when we get older that risk increases, because our bodies don't protect as well as we get older. We're talking about aging and longevity. But when we start to see women having cancer at a younger age, or we do genetic testing and they have the genes that are going to increase the risk for an estrogen receptor positive cancer, that's different. That's a different conversation. And so what I think in context, bringing it back to that study, is that everyone then felt every woman who takes estrogen hormone replacement therapy is going to significantly increase, or even some people were like, I'm going to get breast cancer. And so that's really where we have to take that message and saying, what is your risk of having breast cancer when taking HRT, and what was it that caused? So now we know that it was more of the synthetic progestin, but also it didn't significantly increase breast cancer to rates at which everyone who's exposed is going to get it. Let me make it simple. When we look at breast cancer rates, the rate at which we prescribed HRT from back in that study went down by 84%, right? It like took a nosedive. The amount of women who were off breast or HRT at that point, we should have seen a reduction in breast cancer rates, right? Did we? No. And so that alone should be able to express the validity in HRT not causing breast cancer. When we look at breast cancer, a more heightened risk of getting breast cancer is if you say have 2 drinks of alcohol a day, or obesity. Those are actually going to increase your risk of breast cancer more than estrogen.
And I think that people, they worry about the risks of taking
Yeah.
hormone,
Yeah.
for sure. But something that I've heard you talk about is that there are also risks of not taking it, right?
Yeah.
We talked about frailty, about losing muscle mass. We talked about potential heart disease.
Yeah.
I mean, even we have receptors on our brain and that cognition, loss of cognition. So how do you talk to your patients about kind of weighing those risks for themselves?
Yeah, there's a movie. I don't remember the movie, but it was the guy, I think it was Ben Stiller, and he was a risk assessment officer.
Oh, yeah.
Oh, yeah.
For like insurance companies.
Yeah, like if you skydive, like his client was always skydiving. He's like, no, that's really high on your risk assessment chart. I think that's our lives, is everything comes with risk. And so that's going to be different based on gender, your family history, your personal medical history, how you live your life. Are you someone who's paying attention to the things you put in your body and exercising, right? This all creates risk. So when we think of HRT, I would never say, oh, there is no risk with taking HRT. I would say, yeah, there are some risks. Same thing. What is your personal history? What's your family history? But then also, if you don't take it, there are risks from a longevity perspective, which is why I love to bring the longevity aspect into it. Because when you look long term, just like you said, Whitney, is the risk of cognition because of brain. We know that dementia, when we think of all dementia cases, 70% of them are women, right? More likely to get dementia if you're a woman. What do we now know when we think of the book, The Menopause Brain by Dr. Lisa Mosconi, is a lot of that shift in creating dementia and cognitive issues later on in life happens when we have a decline in estrogen, mainly that menopausal transition. When we look at heart disease, we already talked about heart disease and that increased risk. When we think of our bones and our muscles, we lose muscle mass normally, but when we go through menopause, it like goes exponentially. Our bones, estrogen receptors, you can see, look at a DEXA scan. And when you look at someone who, after they've gone through menopause, that lack of estrogen creates such a significant decrease in bone density. So that's why we have women who get older. We live longer than men, but more time spent in poorer health. Why? Because our heart, our bone, we're falling and breaking our hips, our muscles, so we're not strong. We don't have muscle strength. And then cognition. So then, we're just having these cognitive functions going into dementia. So again, we all get to choose risk assessment wise what we're going through now as far as symptoms. What's the risk of me specifically taking hormones? But also, what do I want my life to look like later? And I get to make a choice now in what I get to put into that kind of deposit or that bank.
And when we put on our kind of, I guess, maybe anthropological hat or even, I think, spiritual one.
Yeah.
What are some of the benefits that come for women through this transition? Like, I think it's clearly pathologized and it seems like it needs to be because there are ways to help it. But what are some of the offerings, do you think?
Yeah, we spend 40% of our lives in that postmenopausal phase. And I think what we in society, and also a little bit of patriarchy when we think of how women are valued or deemed, it creates this culture of like constant hustle. And I do believe that we have this opportunity in this transition is to rebrand ourselves, right? Because this thing is going to happen, right? We don't get to escape it. But how do we get to rebrand our lives? And I think that menopause really is this moment to an invitation to slow down, to really pause our reactivity and responses to this transition and tune into ourselves. That's the inward work and the beauty of tuning into our nervous system, reconnecting with our body, and using that wisdom in order to go through this highly physiologic, emotional, and intense transition so that we can go through it with grace and resilience.
I love that because I think it's so hard to be a woman in this kind of culture and society and not think of part of your value as your looks, as part of your worth and how you kind of are valued in this world. And so when something like, even postpartum was such a big change from like and pregnancy was like how I was used to looking. But that feels like just like a moment in time versus the next chapter, like menopause can feel. Yeah. I love what you're saying where maybe we can like reframe and restructure how we value ourselves. And then maybe that will be part of the change in how the world sees women as we age.
I hope so. And I think that that's part of the messaging and what I put out through my book, but also how I live my life and how I would love to encourage my patients to feel empowered rather than downtrodden and ashamed.
I kind of want to ask one more question if you have a few more minutes. How much do you look at gut health when it comes to menopause, perimenopause?
Oh, I love gut health because the science behind the GI system has exploded over the last 5 to 10 years. And what we do know is that there's so many connections between the gut and the brain, or the gut and your mood even. And so estrogen, again, receptors all over the gut. Intestines are really long. When I do surgery and I look at the gut, I'm like, how do you take up so much space? Because you're really long. And what happens over the course of time with aging and decline in estrogen is it's kind of like if you have a screen, if you think of a screen on your window, the ability of those kind of small holes start to open more. So now we have things going out that really should stay in and things that were outside that now get to come in. So the ability to restore that microbiome and the amount of bacteria that should be around, the good bacteria versus the bad, that has a lot to do with estrogen. So again, HRT really can come in and help restore. In addition, this is the light work, is making sure what you put in your body, which is why I love Sakara, and being able to offer wholesome nutrition to help restore that gut. So it helps with our mind, our cognition, and our mood.
Because I think it's a bit of an overlooked aspect when it comes to perimenopause.
Mm-hmm.
The gut, it helps to break down your food and assimilate your nutrients. If you're eating additional protein, are you actually absorbing that protein?
Right.
And there's so much connection and so many studies now talking and showing about that connection between gut and poor gut health and sarcopenia, the loss of muscle. Yeah. And so I think that this is an important part of the conversation, making sure that we're taking care of our gut health in order to take care of our muscles, our bones. And also, you have me thinking about all the autoimmune conditions that women can face later in life and protecting ourselves against those as well through the gut.
And that's why, that Danielle and you have been able to take this passion of how important nutrients are to our overall experience. And, with Sakara is that women have, one, the flexibility to have something to sustain them, even in the moments when we're so busy, because it's really so important for our overall health to pay attention to our nutrition and our gut health.
Beautiful. Do you see patients on Zoom or in office?
I do.
Where is your office?
Yeah, so I'm based in Dallas, Texas, and we have Sanctum Med and Wellness is our practice here. Because again, we incorporate so much of the wellness aspect into your health journey. But I also see patients via telehealth. So love to be able to do that. So definitely come and see us.
Well, you are definitely an empowering person. I love being around you, and I loved this conversation. And I would love for you to give our listeners some light work to take on with them.
Yes, I love light work because I see a lot of patients in the office or the operating room. And there's magic that can happen there. But that light work, as you call it, really is the ability to take it outside of that. And I would say that sometimes give yourself that moment again to sit and pause and really allow for the moment of, what do I want to reclaim for myself in this journey as a whole body experience? And I hope that we can use the mindfulness and the inward work to actually be a bigger part of the journey of menopause. And so it doesn't sound as daunting, but really take time for ourselves individually to take that moment to say, what do I want the rest of my life to look like? And now go forward in using those tools to find that journey for yourself.
I love that.
Amazing.
Thank you so much, Dr. Shepherd.
You're
It's been such
welcome.
an honor to have you today.
Thank you so much.